Sydney, we can start, beta.
Yes. Good afternoon, all of you. I myself,
Have you
Dr.
started the recording?
Yes, ma'am. Start the YouTube live also. Recording has been started. Yes, ma'am. Recording is started.
Yeah. A very good afternoon. A very good afternoon to all of you. Myself, Dr. Sini Venugopal, on behalf of CCC Wisdome webinar series, invite all of you to our 25th episode of the CCC Wisdome webinar series, that is Confusion, Clarity and Consensus on Infections in OB-GYN. So today we have among us two very eminent speakers, Dr. Bhaskar Pal sir and Dr. Jam Kannan ma'am. And today we will be having two keynote talks. The first keynote lecture, it will be by Dr. Bhaskar Pal sir on congenital infections in pregnancy. And the second keynote will be by Dr.
Vipin, please mute
Jam
yourself.
Kannan ma'am.
Vipin, mute yourself, please.
And the second will be the second keynote will be by Dr. Jam Kannan ma'am, and it will be inflammation, infections in reproductive life. And this series, the webinar series, this is a program which has been very beautifully conceptualized by the very dynamic Dr. Anju Soni ma'am. I would like to welcome now Dr. Anju Soni ma'am. She needs no introduction. She is the HOD of the Gynec Department of the Soni Group of Hospitals. She is the President IMS 2024-25 and the Secretary General of IMS from 22 to 23. And she is also the Governing Council member of ICOG 23 to 25 and member India CCM 22 to 25. She was the chairperson of the HIV and AIDS Committee of FOXI from 20 to 23. And she has also got the IOG Excellence Award 2024. And she has numerous awards and accolades to her credit. And her areas of interest are high-risk pregnancy, critical care, gynec, minimal invasive surgery, urogynec, and menopause. So I welcome Dr. Anju Soni ma'am for this 25th episode of our webinar.
You're muted.
Anjuji,
Anju, unmute yourself. Anju, unmute yourself.
Yeah, thank you very much, all the senior faculties for joining today. We are very, very happy to welcome all of you on our 25th series of webinar, which is focusing on infections in OBGYN. And today, and we have a very, very senior chairperson who will guide us through the presentation, Dr. Kiran, who is president of MOX, and which is such a huge organization, and Dr. Anita Singh, who is again a very dynamic lady with a lot of accolades with her, and also she has been vice president of FOXI. So we all know that congenital infections are those that are transmitted from mother to the fetus during pregnancy, and these infections can have severe implications for fetal development and long-term health. And there are many, many important infections which can occur to the children from TOSH, that is toxoplasmosis, syphilis, varicella zoster, parvovirus, rubella, CMV, and each of these infections can cause range of complications, including congenital anomalies, growth restriction, neurological development. These infections can be transmitted through placenta during the childbirth through breastfeeding, and the risk again include maternal infection during pregnancy, especially in the first.
Faster, shop upstairs.
And second presentation is presentation is again very, very important for all of us, talking about inflammasome during the reproductive lifetime. And we all know that these are basically fungal pathogens that can colonize and in the reproductive tract, and it thrives in warm and moist environment, making reproductive tract a susceptible site. The symptoms can range from irritation and discharge to severe pelvic pain, fever. In some cases, it could be asymptomatic and detected only through routine screening. It has a very great impact on fertility as well as pregnancy. So it can lead to infertility, scarring, and blockage of tubes. And in the pregnancy, it can lead to complications such as ectopic pregnancy, preterm, and low birth weight. There are also risk of infection transmitted to the fetus leading to congenital infections. The diagnosis is typically made through culture and sensitivity, vaginal and cervical swabs. Imaging studies may be used to assess the extent of infection. So let's delve deep into this problem with our senior and expert chairpersons, Dr. Kiran and Dr. Anita. I would like Kiran sir to invite Dr. Bhaskar Par for his deliberation.
Yeah. At the outset, a very warm welcome on behalf of everyone to this CCC series. And I would like to congratulate Dr. Anju Soni. And you are doing a wonderful job. And I think we will see you further for the next year. I hope, wish and pray that we see you in the next year in a better position in the position of VP of the Foxy that you are aiming for. And wish you all the best for the time. And it gives me a very great pleasure. And I also thank you for considering me to be the chairperson of two great academic talks. One is, of course, by Bhaskarda and second by Dr. Jayam. And you know, these two are the people who are regarded in a very high respect and regards in Foxy because of their academic credentials. So it gives me a great pleasure to introduce my elder brother in Foxy, Dr. Bhaskar Pal. Dr. Bhaskar is a senior consultant and gynecologist at the Apollo Multispeciality Hospital at Kolkata. He is the chair of the AICC RCOG in 2021-2023, and he was instrumental in the collaboration of AMOGS with RCOG. And I would like to thank on the record Bhaskar for the same. He was the vice president of Foxy in 2017. He's a clinical examiner at MRCOG Part 3 examiner. He is the author of over 40 papers and book chapters, a very highly acclaimed academician. He is also the chair of the organizing committee of the AICOG in 2023 Kolkata, which all of us have enjoyed to the hilt. And he was the president of IIG. During his tenure, we have seen a lot of changes in the Indian Academy of Endoscopic Surgeons. So a lot of things which have changed because of Bhaskar. And we are sure that because of Bhaskar, we are going to see a lot of changes in Foxy also whenever he takes over at the helm of Foxy. So wish you all the best, Dr. Bhaskar Pal, and we would like to listen to your talk on congenital infections in pregnancy. Over to you, Dr. Bhaskar.
Thank you, Kiran, for the kind introduction. I hope I am audible. Hello.
Yes, Dr. Bhaskar, you are audible.
Okay, that's fine. So I bring you greetings from Kolkata, the virtual greetings, and a small appeal that I have been associated with Foxy leadership positions for more than 17 years, and I request your vote and support for the post of Foxy president. The elections happen from August 1 to 10. I will speak on congenital viral infections in pregnancy, and it is a very, very complicated topic and full of confusion, and some things are very, very difficult to understand. But what is important is that what makes it confusing is the risks of transplacental transmission and fetal damage are pathogen specific as well as gestation specific. At the present moment, amniocentesis is the mainstay of diagnosis of fetal infection, and ultrasound surveillance remains the primary tool for detection of an affected fetus. Therapeutic options are very restricted. In some cases, we can do intrauterine blood transfusion. In some cases, we can do maternal antibiotic therapy, like in toxoplasmosis infections. We all know about the TORCH infections. I will not talk of toxoplasma because I'll try and restrict it to viral. So there is rubella, there is cytomegalovirus, and there's herpes simplex, and the others include human parvovirus B19, varicella, Coxsackie, and HIV. Now, why should we test? Now, essentially, routine testing of TORCH is not really recommended. We should not do it in any pregnancy. We should not do it in a recurrent miscarriage. The testing only tells us about the maternal exposure to infection, and the suspected fetal infection, we need to know the limitations. But we do a TORCH test following a late miscarriage or an IUD in trying to find a cause. I will start with cytomegalovirus, which is a DNA herpes virus. Humans are the only host. The incubation period is 3 to 4 weeks. There are multiple strains, and they provide a cross protection of around 60 to 70%. The problem is that after an initial infection, CMV remains in a persistent state within the host. The immunity against the virus controls the replication, but intermittent viral shedding can still take place in an immunocompetent person. The congenital CMV is one of the most common congenital infections. The incidence is 0.5 to 2% of live births, is a leading cause of childhood deafness, and the primary infection is usually asymptomatic or gives rise to a mild illness. Now, congenital CMV is mainly related to primary maternal infection and not reactivation. The risk of vertical transmission is 40% in the first trimester and the second trimester, but it rises to 80% in the third trimester. But it is usually asymptomatic after 27 weeks of gestation, and in recurrent infection, which is a reactivation, the transmission rate is much lower. It is in the region of 1 to 2%. Now, it can give rise to a lot of problems, including ocular defects like chorioretinitis, but it is sensory neural deafness, which is one of the most common presenting features. It can give rise to hepatosplenomegaly and jaundice, purpura, pneumonitis, fetal growth restrictions, and even microcephaly in the severe cases. What is the sequelae? The overall risk of damage is around 25%. Approximately 10% of infected fetuses are clinically symptomatic at birth. 90% we will not show symptoms at birth. Another 10 to 15% of these asymptomatic will develop long-term sequelae, primarily which is a sensory neural hearing loss. And earlier the fetus is affected, worse is the expression of the disease. We understood that in first, second trimester, the risk of transplacental transmission of infection is 40%. It rises to 80% in the third trimester. But the expression of the disease is worse if the fetus is affected in the first trimester. Now, diagnosis is essentially by the CMV IgM, which is the enzyme immunoassay. It may be positive in primary infection and in reactivation. It is usually present within 2 weeks, and it persists for 3 to 4 weeks after the persistent infection. But it may persist at low levels for many years. The false positive rate of IgM is around 2%, and that's why this should not be used, only this one for a definitive diagnosis. Whereas IgG is usually present within 2 to 3 weeks of primary infection, and it stays lifelong. Primary infection is suggested by seroconversion from IgG negative to IgG positive. IgG levels can also be boosted by reinfection, reactivation, and only a 4-fold rise would be considered as good evidence of a reactivation. Also, we can do a CMV DNA by a PCR, which is a highly sensitive technique, and it has high positive and negative predictive values for fetal infection. So there is also a CMV detection of immediate early antigen fluorescent foci, and this is detected after limited growth in cell culture. It's not very sensitive, but it has a very high specificity for transplacental infection. Now, we do not do a routine antenatal screening for CMV because we do not know of any effective treatment in pregnancy, and also because it will be very difficult to differentiate between a reinfection and a primary infection. So how do we diagnose a fetal infection? If we discover a fetal marker during sonographic examination. If the CMV is suspected, we check the maternal infection status first, and if primary infection or reactivation is confirmed, then we do a prenatal diagnosis by detection of CMV in the amniotic fluid after amniocentesis. Now, we should always do an amniocentesis at least after 6 weeks after maternal seropositivity, because we need to allow for accumulation of CMV in the amniotic fluid. If the results is negative, we have to treat it with caution, or we'll have to repeat the test, because fetal diuresis is not established until approximately 18 to 20 weeks. Fetal blood sampling has got lower sensitivity. So for fetal infection, amniocentesis is better. And these are the various sonographic features which are there, which includes microcephaly, ventriculomegaly, intracerebral calcification, leukomalacia, etc. These are pretty similar for many of those. The second one that we move to is a human parvovirus B19 infection. It has a predilection for rapidly dividing cells, mainly the erythroid cell precursors. It interrupts the red cell production. Adult infections are frequently subclinical and presents as an erythema infectiosum, or to the 5th disease, which consists of transient fever, malaise, and arthralgia. Children do have a mild illness, which is characterized by fever and a typical facial rash, which is called the slap cheek appearance. The problem is that congenital infection can cause profound fetal hemolytic anemia, leading to cardiac failure, hydrops, and intrauterine death. And that is why it is one of the frequent causes of non-immune fetal hydrops. Now, 60% adults have serologic evidence of prior infection by IgG positivity, and it appears to confer lasting immunity. The primary infection rate is measured by the frequency of seroconversion. Now, transplacental transmission is very similar to CMV. Sooner the infection, less is the chance of transplacental infection. If it is less than 15 weeks, it's around 15%. In the late second trimester, in the second trimester between 15 to 20 weeks, it is 25%. Near term, it is around 70%. Now, history of a recent maternal exposure or the finding of fetal eye drops would prompt us to test it. The incubation period is 5 to 7 days following exposure, and women are infectious for 3 to 10 days post-exposure or until the rash appears. The symptoms peak around day 9 and the rash may appear up to around day 18 after exposure. Now, if it happens before 20 weeks, there is an increased risk of miscarriage, approximately 10% higher than the background rate. But the more common one is anemia and non-immune hydrops, occurs in 3% with a 50% fertility rate. The non-immune hydrops usually develops 5 weeks after maternal infection, and spontaneous resolution can occur 1 to 7 weeks after diagnosis. If the IgM is positive, there is a 10% risk of intrauterine fetal death, which usually occurs 4 to 6 weeks after the onset of maternal symptoms. There is no epidemiological evidence of adverse long-term effects in the baby in whom the hydrops is resolved. The diagnosis is by serology or PCR. So we can do an IgM enzyme immunoassay, which is detected 10 days after the infection, but it is short-lived. If rash is present, the IgM should be detected. We can also do an IgG, and primary infection is confirmed by seroconversion from IgG negative to IgG positive. The reason we look at that because the IgM positivity may be transient. Or we compare a blood sample for before with a sample taken after illness. So we also do a DNA PCR when the clinical suspicion is high, but there is no history of rash. Where IgM is negative and IgG seroconversion is not demonstrable, that is when the PCR is indicated. Now, fetal blood sampling again is done for diagnosis in the affected fetus. It is especially indicated when the middle cerebral artery peak systolic velocity has about 1.5 multiple of median, or when there is ascites or hydrops. And the mainstay of treatment is intrauterine blood transfusion. It is indicated if the fetal hemoglobin is below the gestational age mean. Now, what is important to remember is mature human parvovirus has a predilection for rapidly dividing cells. So mature erythrocytes are not susceptible to the infection. And the half-life of formed erythrocytes is approximately 120 days, which sufficiently covers for the intrinsic fetal immune system to develop or for maternal antibodies to cross the placenta. Some passive transfer of antibody can be expected along with the red cells from a seropositive donor, which could further aid recovery of the fetus. As we said, the management of affected fetus is essentially with fetal blood sampling and intrauterine transfusion. We need to remember chordocentesis is associated with a 1% procedure-related loss rate. Possible transfusion sites include the placental insertion of the umbilical cord, the cardiac ventricles, or the straight portion of the intrahepatic umbilical vein. At later gestations, we need to balance the risk of intrauterine death against the risk of premature delivery and extrauterine transfusion. The third one we want to talk about is rubella. It is a toga virus, which is an RNA virus. Infection in pregnancy is rare because most women get vaccinated or they get the disease sometime in that adolescent age, and the proportion of women of childbearing age who are susceptible to rubella is 1 to 2%. The incubation period is around 2 to 3 weeks, 7 days before and until the onset of rash until 7 days after the onset of rash. The maternal rubella infection is usually asymptomatic or it is mild. The fetal effects can be devastating if the infection occurs in the first trimester. Now, here is a little different. The earlier infections we saw that the risk of transmission was lower in early pregnancy and higher in late pregnancy. Here, the risk of transmission is higher in the early pregnancy. In the first trimester, it is 90%. In the second trimester, it varies between 45 to 50%. And like the other infections, the risk of congenital infections are highest when the disease comes be the first trimester. So the risk of congenital defects is 90% before 12 weeks, 20% between 12 to 16 weeks. Deafness does remain a risk up to 20 weeks, and beyond 20 weeks, we are not too worried. The congenital rubella syndrome has a spectrum of clinical features, but more importantly is hearing loss, ocular defects, cardiac malformations, and learning disability. It could present with multiple defects and those affecting the central nervous system, eye, and the heart prior to 16 weeks. Others include growth restriction, hepatosplenomegaly, jaundice, purpura, anemia, rash. The late manifestations are endocrinopathies, late onset deafness, ocular defects, and neurodevelopmental problems. We diagnose it by rubella IgM and restrict it to those who have a history of rash or contact. And if it is negative and we have an index of suspicion, the test has to be repeated. It should be taken within 7 days of appearance of the rash. IgM assays, the false positive rate is there associated with IgM assay, and that is why there's a low predictive value of a positive test. So we need to refer the testing with the history of rash, exposure, history of vaccination, as well as previous rubella testing. Now, ideally, we should do a rubella IgG screening before pregnancy, and the patient is susceptible, give her the vaccine and ask her to wait for 3 months. IgG is usually present 1 week after the onset of rash, and it is not reliable for diagnosing an infection. That is what we do a rubella IgG avidity test, which can distinguish between a recent and a distant infection. A low avidity antibody is less than 3 months. Now, the need for prenatal diagnosis will be determined by the gestation. And we need to arrive at a prenatal diagnosis because if the infection occurs early, because there's a high risk of infection and severe malformation. After 16 weeks, the risks to the fetus are negligible. So prenatal diagnosis best reserved for infections in the first 16 weeks of the pregnancy. Now, if the invasive testing is positive, then transmission to the fetus is assumed, and the risk of the damage to the fetus depends on the gestational age. The options would include terminating the pregnancy or ultrasound surveillance to identify features of congenital rubella syndrome. A fetal echocardiography should be arranged apart from fortnightly scans, and many features of congenital rubella syndrome are not detectable by ultrasound. Next, we move to genital herpes. The herpes HSV type 1 affects the oral region, and type 2 affects the genital infections. And after primary infection, the virus remains latent in a local sensory ganglia near the skin, and there is a periodic reactivation when the virus moves from ganglia to the skin. Primary genital herpes lesions at the time of delivery or within 6 weeks of expected date of delivery, we should resort to a cesarean section. If there is a recurrent genital herpes, then there is no need to avoid a vaginal delivery. Genital herpes lesions at the onset of labor, the risks to the baby of neonatal herpes is very small. What about varicella zoster? It is endemic. 19% of the antenatal population are seropositive for varicella zoster immunoglobulin. Primary infection is uncommon, occurs with the incidence of 3 per 1,000 pregnancies. Primary infection could be fever, malaise, and a distinctive pruritic maculopapular rash, which becomes vesicular and then crusts before it heals. Incubation period is 10 to 20 days. Infectious period is 48 hours prior to the onset of rash until the vesicles crust over. It can cause serious maternal mortality and morbidity, including pneumonia. Fetal varicella syndrome is the result of herpes infection reactivation in utero and happens only when the infection occurs prior to 20 weeks of gestation. So this is the incidence in the first trimester, it's 0.4%, and in the early second trimester, it's around 2%. At 20 to 30 weeks of gestation, the in utero infection may present as shingles in the first few years of life. When the infection occurs after 36 weeks or when the delivery occurs within 4 weeks of maternal infection, up to 50% of the babies are infected and about a quarter of neonates will develop clinical varicella. Now, if the varicella develops before 28 weeks, it could give rise to a skin scarring in a dermatomal distribution, eye defects like microphthalmia, chorioretinitis. Also, it can give rise to hypoplasia of the limbs, neurological abnormalities. Now, spontaneous miscarriage does not increase if chickenpox occurs in the first trimester. Diagnosis is by either IgM or IgA. IgG, IgM usually appears towards the end of the rash and persists for 3 to 4 months, and that is why it is of limited use. IgG usually appears within 10 days and provides lifelong immunity, and maternal infection is confirmed by a seroconversion on paired samples. We could also go for an immunofluorescence test or a PCR for the viral DNA. The PCR is particularly useful when lesions have crusted over and a scrape is difficult. And if the woman has got a history of contact, which is a very common situation, we need a blood test to confirm for varicella zoster immunity. If she is seronegative, we give her immunoglobulins as soon as possible. It is effective when given up to 10 days after contact. And if the immunoglobulin is given, the pregnant lady is potentially infectious from 8 to 28 days. And a second dose of immunoglobulin may be required if there is a further exposure 3 weeks after the last dose. For preventing complications in the mother, we use oral acyclovir, and if she presents within 24 hours of the gestation and after 20 weeks of gestation. Acyclovir needs to be used cautiously prior to 20 weeks of gestation. And please remember, it's an unlicensed indication in pregnancy. There is no benefit in giving immunoglobulin once chickenpox has developed. The viral infection, we can use a PCR in the amniotic fluid, but its presence doesn't necessarily imply that it will become a varicella syndrome. It implies there's an infection. Prenatal ultrasound is useful if we can detect things like microcephaly and hydrocephalus, and serial ultrasound should be carried out from 5 weeks after the infection until around 16 weeks. By then, we should know whether we're getting any ultrasound features. Now, there is no conclusive evidence that we can prevent the infection in the baby or ameliorate by giving any maternal administration of drugs. The presence of ultrasound abnormalities in a pattern which is consistent with fetal varicella syndrome and a confirmed diagnosis of varicella before 20 weeks of gestation, a termination should be offered because we expect a severely affected baby. In the absence of ultrasound abnormalities on serial ultrasound scan performed by fetal medicine specialist, we should reassure the patient and tell her to continue the pregnancy. So HIV is less of a problem. We knew that there used to be a high risk of vertical transmission, but at the present moment, the treatment with antiretroviral in pregnancy has reduced the risk of vertical transmission to the extent that if the patient has got a negligible viral load, we can even go for a cesarean vaginal delivery as well as breastfeeding. Hepatitis B, the risk of intrauterine infection is around 5%. The risk of intrapartum infection is around 95%. And in chronic carriers, 90% will have a congenital infections. About 1% of mothers are potential risk for the newborn. So what we give is that we give immunoglobulins for passive immunity to the baby and active immunization of giving 3 doses of the vaccine. Now, hepatitis C is something, again, we don't talk about much, but we started testing routinely. The risk of transmission to the fetus is 6 to 30%. It is increased if there are other co-infections like HIV. There is no treatment. And here we are not sure of the value of a cesarean section. And that is why we actually do not go for any invasive procedures. So essentially, if you can see that what are 3 important points. Number one, that early infection usually carries a bigger risk. Number 2 is that the mainstay is a good ultrasound with a fetal medicine specialist, because just diagnosing infection in the amniotic fluid is not good enough. The risk of transmission varies depending on the pathogen as well as the gestation of that infection. We should always consult with a virologist. For fetal infection, we need to do amniocentesis and then test for infection. The timing is crucial. In many situations, a negative test does not completely exclude the possibility of fetal infection. And therapeutic options are limited to intrauterine blood transfusion in anemia. And again, something we didn't talk about today is maternal antibiotic in toxoplasmosis. So in conclusion, detection of virus is not synonymous with fetal damage, and on the other hand, a negative result does not completely exclude the possibility of fetal infection. And presence or absence of sonographic markers may not accurately predict long-term outcome. Thank you very much, and I'll again end with my appeal for vote. I'm happy to answer any questions.
Thank you, sir. Dr. Bhaskar, sir, you have covered in such a short time so beautifully and covered almost everything. So thank you very much for your deliberation. And Dr. Kiran had to leave for an emergency cesarean. And now I think you have to leave, sir. You have some meeting.
Yeah. It's
so
okay.
I would like to invite.
I'm still connected, don't worry.
Yeah, okay. So I would like to invite Dr. Jayam, who is dear to, I think, each and every one. And she is going to talk about, again, very, very important topic today, inflammasome, and we hardly, a lot of people just don't know that there's something like this exists. And I know her deliberation will be very, very useful for
খুব দেরি হয়ে গেল রে
for attending.
আমি যেভাবে রেখে গেলাম সেভাবেই রাখিস সব
Over to you, madam.
Can I start?
Yes, madam,
Is
please.
my voice audible?
Yes, madam.
Okay. Thank you very much. Had an excellent deliberation by Bhaskar, in spite of all his tiredness which is seen in his face. And that will really become a booming tiredness in a couple of weeks. Now, in 2002, when we had the Human Genome Project, what people are thinking, what are these numbers, 46, 48, all these things. But now we know the importance of it. We have quickly passed through it in the last 22 years. The same way, we have infection, which has got the precedence of inflammation, which we are able to see in our clinical practice. But there is also what is called inflammasome, which is there preceding the inflammation with all the molecular protein level work which is going on in the cytoplasm, about which there are already NLRP312 have come. But 3 is the one which is very particular for the reproductive health. And this is there for the past 15 years. When Anjusoni called me, talk about infection, madam. I thought everybody would have talked about all infections, even in sepsis in pregnancy, sepsis and obstetrics. So I thought, let me take a new topic so that I can work on it and give her a new insight, because she has worked to the Himalayan level in the HIV, and now to be the vice president, she is going down to earth, probably kilometers down the sea, to come and maintain herself in a very high way. So the polarization with the T cells, which we are very well aware, is through the inflammasome. And this is an inflammation which you know with the red cells, WBCs and macrophages. We know how the conglomeration of the WBCs are going to bring out the pus cells out, and we are going to the purulent discharge. All the 3 are not so easy. They are not so good to ride again. It is not so happy to go through it, but let us go through it. Now, in a labor ward, when a woman enters with 101 degree Fahrenheit, a couple of years ago, we used to think that she might be having a urinary infection, and she is all right with all her membranes intact, and vertex station contractions are all right. So once delivery, her urinary infection will settle down. But now, 101 degrees Fahrenheit in a pregnant woman, intrapartum, has got its own great consequences on the postpartum period. So this is being given a lot of importance. So fever in labor, not only to look for obstetric features and site-specific infection, we also have to be very, very careful in the next 6 weeks of our life. What is inflammasome? It is just a multi-protein complex. We know well cytoplasm, the nucleus, everything has got a lot of protein complexes. It is a protein complex which is there in our cytoplasm, which assemble together. They are all staged there. But at the time of any a problem in a hospital, when there is somebody coming and thrashing the hospital, all nurses, everybody, staff, everything come together and try to compensate this thing, hold down the attack. Like that, these multi-protein complexes which are there in the cytoplasm come down in response to cells and takes the body away from their attacks and pathogens and endogenous signals also away. So it has got 3 important components. That is like all our newer ones. We have a sensor, we have an adapter, and there is a downstream to work at. When I say about sensor and adapter, everybody should know, because we are so much in the field of the digital world. The inflammasome is hugely assembled in the placenta. Why? Because placenta is the one which has to prevent the baby from getting any attack. So the inflammasomes containing the molecules of interleukin-1 beta, 6, TNF-alpha, tumor necrosis factor, all there are too much in that. In the obstetric gynec field, totally, it is the placenta which has got the maximum inflammasome, in regular life, keeping the potence, and it regulates the pregnancy by producing then and there pro and anti-inflammatory actions through all these protein complex. The baby is really a miracle. It escapes passing out through the inflammasome, and it shows the beautifully formed anti-inflammatory one. We all know well, maternal fetal immunity tolerance is essential for successful pregnancy because the paternal, this thing is a big antigen. So adaptive systems are very much required. Innate immune systems ought to be relatively activated so that the inflammasome assembles in the placenta and takes care of the dysregulation immune response and devastating consequences. If it is not taking, then only we get all the problems. How this happens? Kindly just hear me at this. As we have a sexual life, for a normal pregnancy, we have a huge number of sperms deposited in the vagina. There are also sperms which are deposited in the cervix. Sperms which are deposited in the uterine wall and up to the fallopian tube. What these things do, they produce the antigen placental cells, which all, even from the extravillous trophoblast, also the APC cells are being produced. And all these things go and ask the lymph node to come out with the cytokines and Treg cells. Now we understand that before pregnancy, not only the fertilization occurs, at the same time, the passage also makes sure that the implantation can occur very clearly with the support of the T cells, cytokines, and Treg cells by all the inflammasome, the kindling, which has gone to the APC cells. These APC cells are the antigen presenting cells, which are scavenger cells. So those which have come from here are the scavenger cells, asking the lymph node to be ready to do the scavenging as and then when there is antibody reaction. With the result, all the apoptotic cells which are being produced with the natural killer cells and all those things get out, and they are able to successfully allow the pregnancy to retain. The picture which I have given is very well explained by the cells which I have given it. Anybody wants can have a screenshot so that they are able to read this very well. Now, the pregnancy has gone through and the scavenger cells have worked. Now, it is waiting for the terminal. What is the terminal? The onset of delivery, and out comes the baby. So the onset of partition is very, very characteristic of these inflammasome reactions. So the local immune reaction, which is in the stage of switch off, is switched on. The decidua, which has been asked to be quiet by all this inflammasome LLRP3, is now activated. So it allows the myometrium to get into action. And so far there was progesterone 4, pre-4 signal. The progesterone signal is withdrawn. Normal labor is the onset of progesterone withdrawal, decidual quiescence being lost, and immunologic tolerance being lost, and out comes a baby and a normal delivery occurs. But is it the same in preterm death? No, preterm birth is often a process of big placental inflammation with low-grade maternal vascular malperfusion. And it is a breakdown of the fetal-maternal tolerance along with excessive premature inflammation of the placenta. So the term placenta, birth placenta, is markedly different from the preterm placenta. Many of us ask, whenever there is an unexplained preterm birth, we ask the histological examination. But the normal histological examination will not be able to answer us anything unless they go through this inflammasome levels estimation. This is a slide which I could not reproduce, but I had to take it up. Please go through the slide. This slide has got the requisites for successful pregnancy. What are the challenges which are there for the request? What is the outcome? With the successful luteal by progesterone level, good quality seminal fluid without too much of prostaglandin and inflammatory cells. If it is not there, there is no infertility. But if it is there, infertility comes. And then, well, right, the gamete has been formed. This zygote has been formed. There is a difficulty in the implantation, which is again a process of progesterone signaling and immune tolerance. And if the decidua is able to be quiet and accept the baby, all things go on. If it is not there, with the age, ethnicity, lifestyles, all the genetics and implantation failure. The next thing is when the placenta is being put into this NLRP3, miscarriage, and then comes the preterm delivery. So all these things are at one shot with these changes which are going on. About chlamydial infection, already Bhaskar Pal talked about the avoidance of excessive inflammation is very much required for a chlamydial infection not to produce any problem. When it comes to preterm birth, what happens? NLRP3 is one of the constants of this microprotein group, and it is highly increased in preterm birth. And it gets activated whenever there is an amniotic infection, when the membrane ruptures, and this says, no more I am able to tolerate, allow the labor to set in, let the cervix dilate, let the baby be out, so that I am able to be quiet. That's what it says. The next problem we get whenever we talk about preterm birth is preeclampsia. Preeclampsia, we know all about these things. It is a process of placental ischemia with inflammatory cytokines, microparticles, inflammation, coagulation, activation. This slide is known to all of us. But how this slide works, nobody wants us to see because it's such a big slide. This is one thing. What happens? The same inflammatory microproteins, which are molecular proteins, which are accumulating in the cytoplasm, is going into all the maternal system of cardiovascular, renal, and hepatic and central nervous system, resulting in hypertension, proteinuria, edema, and whatnot. The inflammatory response based on this is the deposition of the leukocytes, endothelial cell activation in the cardiovascular system that leads on to preeclampsia, which we all know well is impaired spiral artery remodeling, endothelial dysfunction, and excessive maternal systemic inflammation. These three are explained by this. Next we have unexplained fetal growth restrictions. Mother's weight is going on. She doesn't have diabetes, hypertension, or anything, but still the baby is not growing well. It's because, as Bhaskar has put in, there could have been some low-grade chronic infections which would have produced this activation of this protein inflammasome, which results in interleukin-1 beta, which induces decreased amino acid transport activity. This is trophoblast and sensitive trophoblast, apoptosis, and all of this lead on to this central nervous system problem in the baby and fetal growth restriction because the cortisol mechanism is not going on well. The next which unexplained one is recurrent pregnancy loss. We all know well recurrent pregnancy loss is due to a maternal inflammatory response to the babies which are not able to go through properly. We all know about all the barriers. What is the big barrier here is the lipopolysaccharide levels which are very much increased. These lipopolysaccharides come not from the body. We all know well that the vaginal and uterine microbiome have got a big role in fetal growth restrictions. The same thing with recurrent pregnancy loss and also going in for preeclampsia. The same thing comes in the gut. From the gut, the lipopolysaccharide levels are going up because of the inflammatory barrier which are created in the intestinal system, which leads on to a big inflammation throughout the body. So, apart from the vagina, uterus, the abdomen also contributes to the microbiome, resulting in the digesting problems. Then, we all know how the vessels are getting damaged in pregnancy complications. We know about the liver complications. We know about the vascular complications. When we get the CRP level increase and the vessels are produce problem, we all know markers are interleukin-6, TNY, the tumor necrosis factor, neutrophils, and macrophages. All these things are related to the inflammation. So now that is why I took the topic triple I in gynecology and obstetrics, inflammation, inflammation and infection. We all have heard much about the natural killer cells, micro beta lymphocytes and other things. And these have been a big pivotal factors for carcinogenesis. And in the natural killer cells which have been contributing to interleukin 18 has also been resulting in the dysregulation, and this is a pivotal role of carcinogenesis in carcinoma cervix. Whenever we have a carcinoma cervix, when I ask for a micropathological characters, we get this big slide also. This slide also talks about the Caspars Townsend, NLRP3, calcium and other things, lysosomal rupture. All these things which are just in slides are now getting explained with this the topic of inflammation being put up very much for the past 15 years. We all know cancer cervix is extraordinarily common in women because of this problem. HPV also, we have known about it. The complex immunological system, which are regulating these inflammatory changes, are the need for it. Now we switch on to the second I, that is the inflammation. We all know inflammation means it is again a shock to the body, and it is being expressed in the form of big cellular stress with pain, heat, redness, and finally the final changes of the irritation, which results in the damage and failure of the organ to work. And the inflammation-related problems in gynecology are not only the one which are seen with the fever, leukocyte changes, CRP reactions, all those things. We even have a normal affection of the ovulation and hormone production. We have thyroiditis. We also have euphoritis because of the silent inflammation. Endometriosis is big, this thing which we have now understood is a process of inflammatory product. It is not just the endometrial cells going outside through the fallopian tube, getting into the peritoneal cavity and producing a regular cyclical response. It is the inflammatory product, characters of these cells which are resulting in the endometriosis. Otherwise, if you are able to get the cycle acyclical with long doses of oral contraceptive pills, she should not have endometriosis, but still we have endometriosis. That is why this is becoming a disease. We now have also what is called endometrial cell development, endometrial cell functions, and receptivity. That is why we are doing endometrial receptor assay. ERCP is being done in recurrent implantation failures. All these things are characters of this inflammatory pathology. Then we have a big thing called autoimmune disease, which is very, very characteristic only in the female. 80% of the autoimmune diseases are coming out only in the female. Why? It is because female have got 2 X. Xest molecule is characteristically attached to the chromosome X. The immune molecules, all these problems. Nature 2024 has come out with it very clearly. And because there are 2 X's in the female and there's only 1 X in the male, and the Y is able to dominantly suppress these molecules, autoimmune disease is not there in the male and it is there in the female only. We have called about sterile inflammation. What is this sterile inflammation? There is no bacteria, there is no infection, but still there is red changes. We have said, dermatologists will say it is just a sterile inflammation. These are the inflammation induced by the inflammatory disorders going in for all the problems of preterm birth, neonatal hypoxia, and encephalopathy, down to that. Now come to the viral disease, which does not produce too much of polymorphs, increase. Some parts of these things which are known to everybody. And the fungal infection, which is normally the Candida albicans, which is there in the body of everybody. In some people, it starts producing the infection, Candida albicans, they say. All these infections, vaginal microbes, which are normal, turn into problems because of this NLRP3 initiation with a neutrophil recruitment, which occurs only in some of the cases. Next, can you have hormones also upgraded or downgraded with inflammation? Yes. Endometriosis is a characteristic example of these hormones and inflammatory pathology. Donors 2023 has worked very much on the fibroids and endometriosis, has put it out in the 3 distinct forms of peritoneal, ovarian, and rectovaginal endometriosis. The exact pathogenesis is challenging. Here, the gut flora, the vaginal flora becomes the key regulator factors which are producing all these changes, and that research is going on. Then we have what is called the endometritis. Somebody does this thing, hysteroscopy for a failed pregnancy. They find strawberry-like endometrium, where they see appearance of the endometrium. That is because of these chronic infections which could have occurred, which could have also been following a delivery. Now, do we have markers of this inflammation and infection? Yes, we know about all these CRPs and other things. But these markers of inflammations are mainly now with interleukins, TNF-alpha, and tumor necrosis factors only. ESR, C-reactive protein, and plasma viscosity to a certain extent help. White blood cell count, ESR, comes more with infection than the same. Procalcitonin is now coming to be a generalized marker of sepsis. However, if you are able to do a specific culture and prove the anti-infection, that is where it ends. Can I manage in a better way? Yes. If you are not able to diagnose an infection properly, and if you have only unexplained fever, how do you manage the fever? With non-steroidal anti-inflammatory drugs, accepting that it is an inflammation process, aspirin and ibuprofen, and then finally with corticosteroid, which is a king of anti-inflammatory drugs. And why we use all these hydroxychloroquines in recurrent implantation failure or RPL is because anti-malaria medications also are able to take care of the inflammation. And finally, for the vascular problem, we are now coming with low molecular weight heparin also. The key points of this lecture is inflammasome are a group of cytoplasmic multiproteins which are scattered in the cytoplasm, get assembled in problems of stress of these problems. Involves a pathogen-associated infective process. Dysregulate immunity by triggering inflammatory responses. Reproductive health is getting disturbed by pregnancy complications, menstrual cycle irregularities, endometriosis, and carcinoma cervix by these things. NLRP12 have been so far identified. Number 3 plays a key role in reproductive problem. I really thank Anjusoni for allowing me to be a different person among all the sepsis lectures which are being given by everybody, and wait for another opportunity from Anjusoni for an excellent, for a lecture like this, which may be little, not too much understood, because it is something which I also took 15 days to understand once Anjusoni called me to deliberate this. Really bless you, Anjusoni, for a beautiful, the bright light like this in your life in the next 3 weeks to come. All the best to you. Thank you very much for this opportunity.
Thank you, Dr. Jam, for such a wonderful lecture.
Thank you.
And the topic was actually, most of the things were very new to most of us, whoever is listening to your talk. And you have put such a great labor in preparing this paper. I really, hats are off to you. It was wonderful listening to you. Although all the points we could not, assimilate in such a short time, it will take, I think you will be taking this lecture in some form or other.
No,
in
Dr.
other
Anita,
also.
Dr. Anita, we put all our webinars link in the groups, all the groups, and anybody can watch it.
Yes.
They are YouTube links. So
But
anybody
What
can.
Madam is referring is this 15 minutes, 20 minutes is not enough. I
watch
should
it
have a
anytime.
bigger
But I
oration
watch these
on this.
webinars again.
It was just an introduction. We could get introduced to the inflammazone and inflammasomes. I think these are the new things and the new concepts which are coming up. And in the future, I think we'll be ready with many solutions for the ladies, especially the poor ladies who are suffering from different repeated pregnancy losses. We will be in a position to help them out when we feel helpless.
Yes.
So that was a great effort on your part, Dr. Jam. that you
Okay,
have.
thank you. Thank you.
Very
Anju will
important.
call me to give an oration on this for 1 hour. In her
Sure,
next-
in the future, I'm
Madam,
going
that
to.
is what I was, when you were talking, I was thinking that only, that this needs an oration, you know.
Yeah, triple I's in
Needs an
obstetrics
oration.
and gynecology. That is
Yeah,
a
Yes.
because you can, you know, you needed more time to talk about it.
Yes, yes. And
Absolutely.
Dr. Anju, lot of thanks for inviting me for this wonderful webinar where the two stalwarts were giving their lectures. Even Dr. Bhaskar's lecture was very informative and very refreshing. We could all revise the things that we are practicing. So it was very good attending this program. Thank you very much and wish you good luck for the future. And I hope you are going to have fly in your future also, as you are IMS president and all that post you have been holding and doing so well justice to all those posts. So thank you very much. And once again, good luck to you. Thank you.
Thank you. Thank you.
Thank you, ma'am. Before my superstar conveners, coordinators speak, I would like to request each and everyone to please support me for my next venture in life, which is very, very near. As Dr. Bhaskar Pal has said, that the voting is starting from 1st to 10th August. And I'm sure all of you will give me just one vote in the West Zone.
Yes.
Not more I need.
Yes, yes. Done, Anju, don't worry.
Yeah, thank you so much, madam. I
Thank-
need support from both your zones.
Yes,
It's
yes.
also very essential from south as well as from east.
Yeah,
Of course.
sure.
Thank you, ma'am. Thank you so much.
Thank you.
And
Thank
it
you. All
was
the best for
really
you.
wonderful to have all of you today, Dr. Bhaskar, Dr. Kiran, Dr. Anita, and Dr. Jayam. Lecture was icing on the cake because
Thank you.
because everybody talks of every other thing. So our team thought of coming out with something different, which has not been touched by anybody. And I'm very, very excited that today is our 25th webinar, and all the webinars have such beautiful content, and there is a lot of people, who are having the views, because we put the links for everyone to listen. Sometimes you don't have time, you can listen to them once again whenever you are in leisure. Listen to them in your own speed, in YouTube you can increase the speed also to double, 2 times speed, so you can see the webinar in half an hour time. So that is the best part of YouTube links. So that is how we started working on it. So over to you, dear friends, to give the vote of thanks.
Good evening, everyone. At the outset, I would like to thank all the speakers, Dr. Bhaskar Pal sir, for his wonderful deliberation on congenital infections in pregnancy, and also Dr. J.M. Kanan ma'am for her beautiful presentation, and it was very informative. Thank you so much, ma'am. I would like to thank our chairpersons, Dr. Anita Singh ma'am, for her inputs today, and also Dr. Kiran Kortakoti sir for giving his precious time. And I thank my coordinators also, Dr. Manisha Jain and Dr. Simi. Thank you so much. And last but not the least, Anju Soni ma'am, who is the main, what we can say, actress of this webinar. So thank you so much, ma'am, for giving us the opportunity. And I would like to thank all the participants who have logged in today, and who
I'll
have
say
taken...
not put as actress, I'll put as the queen of this webinar.
So thank you so much, ma'am.
We are coming with an exciting. Next week also we are coming with an exciting topic. I'm sure it will interest each and every one of you. So keep waiting for next Wednesdays, so that we have a beautiful session next, which is also a very, very practical session we have planned for all of you. So looking forward to meet you all at 4 p.m. next Wednesday. So thank you very much, and over to you, dear.
Thank you so much. Thank you, everyone. And see you in next week.
Okay. Okay, ma'am.
Thank you, ma'am.
Thank you, Simi. So
Thank you,
I
ma'am.
can leave this.
Thank you,
Yeah,
ma'am.
Thank you,
sure, ma'am.
Anju. All the best for you. Okay.
Thank you, ma'am. Thank you so much.
Yeah. All the best for you. Thank you.
Are you coming to Mahabalipuram, ma'am? You must be coming there.
Yes. I'll be there by Friday afternoon. because tomorrow is Baba Day, so
Okay.
nobody can steal my day from away from Baba. So tomorrow I pray the Chiddi Baba, and Friday morning I am there and leave on only Sunday evening.
Anju ma'am, shall I stop the recording?
Yes, please.
Yes,
Thank
please.
you, thank you, thank
Thank
you.
you.
Please.
I'll be
Thank
there,
you.
Anju.
Thank you so much.
Thank you. We'll be. It is
Thank
making
you. Thank
this
you,
new-
Walter.
Thank you. Thank you. Thank you.
Okay, ma'am. See you soon. See you soon, dear friends.
Thank you, ma'am.
Bye-bye.
Thank you, ma'am. Bye.
Bye. Thank you.